Hello everyone. I'm Ashwin Ramon. I'm a liver transplant and HPV surgeon and the Director of Academics and Research at the Rela Institute, Chennai. On behalf of STETHUP and the Liver Transplant Society of India, I welcome you all to this session on one of the most transformative and exciting developments in healthcare, which is the integration of artificial intelligence, or AI, as it is quite fancifully called these days, into the field of healthcare and medicine. For centuries now, the basic practice of medicine has relied on expertise and intuition of healthcare professionals to treat and manage diseases. However, with the rapid advancement of technology, we are now in something which is new to healthcare, one where intelligent machines work alongside physicians to enhance outcome and, of course, change the way we approach medicine. This evening, we will go into the fascinating world of AI, explore its potential, its challenges, and its impact on the future of healthcare itself. We'll also explore how AI is already being used and is likely to be used in the future. But again, what's sobering is that with these exciting opportunities come important safeguards, questions, and considerations, some as simple and as profound as, will AI replace a human doctor in the future? So to answer all these questions and more today, we have a talk followed by a panel discussion of experts. Our speaker today is Dr. Mamatha Bhat, who is a hepatologist, clinician scientist, and the co-lead of Transplant AI Initiative, Ajmera Transplant Center. She is also the Associate Professor, Division of Gastroenterology and Hepatology at the University of Toronto. She does balance quite a few hats at the same time. She has completed her transplant hepatology from the Mayo Clinic, followed by a PhD, has over 150 publications, and has won several accolades for pioneering research in the field. Now, her research program aims to improve long-term outcomes of liver transplantation using tools of AI with bioinformatics in the care of liver transplant recipients. Mamatha, thank you for taking the time out to educate us on the topic. The floor is yours.
Thank you so much, Dr. Rammohan, and it's my pleasure to present to all of you today my insights into developing AI tools in medicine. And so I'd like to thank Dr. Kaliamurthy and Dr. Rammohan for having invited me to give this talk. I'm also happy to address questions from the panelists during the talk. I think, as long as I'm on a certain slide and the content is of interest for a question, happy to address any questions also along the way. So now I'll share my screen here. Okay, so as Dr. Rammohan mentioned, I co-lead our Transplant AI initiative at the Ajmera Transplant Center, which is one of the largest transplant programs in North America. And this offers us an interesting opportunity to collaborate very closely with our computer scientist colleagues at the University of Toronto, who really have a great deal of expertise in developing AI tools really to address and suit the clinical nuances of a question. Additionally, we have an infrastructure that also permits deployment of these AI tools into clinical practice, and this offers us interesting opportunities to prospectively evaluate the performance of these tools in real time. Here are my disclosures. So I'll start off by going over what is artificial intelligence and some current healthcare applications that are out there, and may be of interest to all of you depending on the specialty you practice. I would say that the lessons that I've learned along the way through my interactions with computer scientists, having co-supervised many graduate students and postdoctoral fellows in these projects, has brought some interesting insights into how you can really collaborate in an effective and productive way with computer scientists. So I'll try to offer some of those insights, and also happy to address questions during the panel discussion as well. I'll get into why machine learning in liver transplantation specifically as an example of a field where we have been able to successfully develop tools suited to the clinical nuances of questions. And these include projects looking at dynamic trajectories on the liver transplant waitlist, looking at optimizing patient survival as well as graft survival after transplant. So these are different projects that just illustrate the potential for AI tools to help us kind of reproduce and decipher the complexity of the data that we generate on a day-to-day basis. So, what is artificial intelligence? Well, AI combines different traits, as does intelligence, so learning, reasoning, problem solving, etc. But AI specifically refers to intelligence demonstrated by machines. And so there are many valid definitions. The most commonly employed one is computer systems that use information and act in a goal directed manner. And you can appreciate, I know that everyone is, say, interacting with AI tools on a day-to-day basis, especially after the arrival of generative AI solutions such as ChatGPT. This is really, say, revolutionizing interactions on a day-to-day basis. Say, when you do a Google search, for example, even that is, say, leveraging an AI tool that kind of predicts what you are likely to be looking for. Say, when you do a search on Amazon or some other a portal, often your history shapes the sorts of options that are proposed to you. So I think we have AI all around us, and the question is, how can we really bring this into healthcare in an effective way? So certainly, AI has been a bit slow to come into healthcare practice specifically. It's been widely adopted across different fields, including business and technology, engineering, etc. Now, in healthcare specifically, there are different applications, including AI-assisted surgery. So I know that in India, there's tremendous developments in this regard in terms of robotic surgeries, and certainly AI-assisted surgery. So, say the Rela Institute, among other institutions, are, leading the way in this regard. Natural language processing offers the opportunity to, say, digitize doctors' notes, even, say, for more basic translational applications. You have different potential say, methods, etc., that can be used. Additionally, on a more practical level, there's the opportunity even to automatize scheduling, say, of nursing shifts or doctor shifts. So there's a lot of opportunity to really leverage AI for making our lives simpler and more efficient. And ultimately, also, most importantly, optimizing patient outcomes and healthcare outcomes, decreasing healthcare costs, et cetera. So there's a lot of opportunity. Now, how can we really optimize that? I think, I'll offer some insights, but I think a lot of it is getting educated about the opportunities, and also, say, really learning to understand the computer scientist's language and vice versa. So the computer scientist also trying to learn healthcare related questions and understanding the context of what they're doing. So specifically, machine learning is a subset of AI, and it's a field of AI that allows software applications to become more accurate at generating predictive models without being explicitly programmed. And this allows you to detect hidden patterns and interrelationships within large data sets. deep machine learning or neural networks are a subtype of machine learning algorithms. So, I can tell you that I got started in AI back in 2017. So I was still actually completing my PhD. So I completed my PhD in 2018. But there was this really compelling article that came out in JAMA on skin cancer lesion recognition, and then another paper that was quite exciting on diabetic retinopathy. So it struck me that as a hepatologist, on a day-to-day basis, I was constantly trying to decipher patterns in data to generate personalized predictions for the patient in front of me. And I thought it would be very interesting to then explore the opportunity that AI tools could bring to clinical and laboratory data. Now, granted, most applications in AI and even FDA approved applications tend to be more imaging based, so radiology and pathology based. The vast majority of FDA approved applications, so FDA meaning the Food and Drug Administration in the US, applications are imaging based, and there's a plethora of such applications. But I think there's a rising number of applications that are out there that can, say, leverage patterns in data, whether it's clinical and laboratory variables, to really generate personalized predictions. So whether it's diagnostic or prognostic predictions. So really, I would say, in 2017, that prompted my interest, and that's when I started looking into potential collaborators at the University of Toronto. So I started reaching out. I emailed various people, and one specific person was especially interested and was, say, a key leader in the field. And we started working on a project, which ultimately led to an excellent paper. And then same thing. So I just reached out to different people, uh, recognizing their expertise in the field and the potential to their, say, unique skill set that could be applied to questions of interest in liver disease. So, and I'm happy to speak more about that later on. But like over time, because we meet on a regular basis, and I co-supervise computer science students and postdoctoral fellows, along with clinical fellows. This has offered the opportunity, say, for me to learn from these graduate students and postdoctoral fellows. And then they also learn by very closely working with the clinical fellows, and also, say, understanding the insights that I have as a clinician. And so we meet on a weekly basis. I have 4 close computer science professor collaborators with whom I meet on a weekly basis, along with our students. And so, by really understanding the clinical nuances of the problem, then the machine learning, students, as well as the professors, can then understand, okay, well, this is an opportunity for us to develop a new method to address the specific question, because we think that, say, a standard off-the-shelf machine learning algorithm will not do the trick. So we really need to explore other methods, and fine-tune other methods, or even develop new methods to address the specific question. So, expanding on that further, I think if we look at machine learning tools versus traditional biostatistics, standard clinical risk models are easier to interpret, but they will assume that a risk factor is related in a linear fashion to clinical outcomes. So, what machine learning tools can do is better incorporate multiple risk factors and identify more nuanced relationships between risk factors and outcomes. And so ML algorithms will learn from existing data to find novel patterns. Now, the disadvantage of these ML algorithms is that they are, say, black box, and there is significant need for processor time to build models, but over time, certainly the speed of such development has dramatically improved and increased. And there's also greater interpretability of algorithm predictions, which I'll get into a bit later. But I think that some of these things that were seen to be downsides of ML algorithms actually are continuing to improve over time, and will result in the potential for, say, trust and applications widely in healthcare. So the machine learning pipeline, this is what it consists of. So collecting and processing input data, choosing the algorithm that can connect the input to the output, collecting the output prediction, and training the process until the predicted and actual result are similar. So here are some examples of deployment of AI tools into healthcare. As I mentioned, a lot has been done in the imaging space. Additionally, predictive analytics and personalized medicine, I think, are now important areas of research where a lot of progress is being made to really provide such insights and personalized predictions. Telehealth and patient engagement, I think, in my research, we do involve patient partners to help them feel empowered in the research that we're generating to make it really applicable to patients in the end as well. And our ultimate idea is to be able to generate patient solutions, say patient dashboards, which can help them feel, empowered in their health and have greater control over their health. Because clearly, having that understanding and control over their health will alleviate a lot of anxiety, can alleviate a lot of anxiety as well. These are, say, important, I think, in research in general. Now, we do have various AI tools that are being developed to increase remote monitoring, as well as, say, virtual health assistants to help patients in their care, offering basic medical advice, scheduling appointments, etc. So there's lots of more practical applications that have been generated. Surgery, so surgical robotics, is a significant area of interest and involves more, say, imaging data, drug discovery and development. So you may be familiar with, say, AlphaFold, which is this wonderful AI tool that was developed by Google DeepMind, so Demis Hassabis and John Jumper. And this has enabled acceleration of drug discovery over time by modeling the 3D conformation of protein structure and informing development of drug discovery. Natural language processing, I alluded to this earlier, digitizing patient notes, etc., fraud detection and billing, certainly in the US, these are tools that are being used. Now, ultimately, and I think we can get into this more in the panel discussion, there are certainly challenges, significant challenges that I think we will have to work on and do research on in the in the coming years, in order to permit safe deployment of AI tools. So, one important aspect, I think, is ensuring that these algorithms are predicting outcomes in an accurate manner. And this will be necessary to inspire trust among both patients as well as physicians. Large and clean data sets are needed. We do need to ensure that there's no bias within those data sets that are going to generate, say, biased predictions. And this certainly needs broader testing and validation, as I mentioned. So certainly in my program, we have research grants from our Canadian Institutes of Health Research, which is the equivalent of the National Institutes of Health in the US, which we are using to understand prospectively how these AI tools are working and ensuring that they will generate predictions that are, say, helpful to patient outcomes in the end. Okay, so machine learning in liver transplantation. So now I'll just focus on specific cases in liver transplantation and give you a sense as to how these projects came about and how we progressed on these projects. And hopefully that gives you some lessons that you can then apply to your own fields if you have an interest in delving into AI within your own medical field. So in liver transplantation, as is the case in medicine in general, I think. So many different factors will affect transplant pathology and outcomes. So, all these demographic and clinical factors, exposures, etc. Additionally, we're constantly looking at complex nonlinear patterns in liver tests and various other blood tests. So is ALT greater than AST? Is alkaline phosphatase elevated? Is the INR elevated? Bilirubin, etc. So, and then what do hepatologists are constantly looking at data in terms of patterns. And so the reality is that the human brain cannot consider more than 4 variables at a time. So it's very difficult to say, consider over 100 variables. So the human brain cannot say take into account more than 4 variables at a time. And additionally, notwithstanding the longitudinal changes in those test results. So the reality is that, say, a patient of mine could have had a normal creatinine, normal glomerular filtration rate 4 or 5 years ago, and then over time, there's a steady decline in their GFR. So I may not realize that, or it may not strike me that that has been happening. But technically, if that is happening, and if that patient is going from, say, a normal GFR to a compromised GFR, then I should be considering changes in the way I treat them. So considering changes in their anti-rejection medication, et cetera. So I think such trends in the data are also very important to consider, dynamics in the data. And certainly AI tools offer us the opportunity of recognizing these things more readily and acting as a co-pilot in the care of patients. Additionally, we have a wealth of data being generated with all of this, say, clinical sensors, imaging technologies, wearables, et cetera. So, as well as omics data, there's so many, say, high throughput omics methods these days. And the cost of such omics data generation has also come down. And so it offers us the opportunity to really practice a more precision based approach to the care of our patients. Here are some applications of machine learning in liver transplantation, and I'll get into these in a bit more detail. And these are published in a review paper we had in Journal of Hepatology last year. So I'd welcome you to take a look at that one. And then we also have, sorry, I forgot to mention at the bottom of this page as well, various reviews on this topic of ML in liver disease and transplantation. Solid organ transplantation and liver transplantation. So please refer to those for any further insights. And I have to say, a lot of these projects and work are driven by very enthusiastic students, residents, fellows. So really, it's a team effort that has led to all of this being feasible. So we have been in terms of ML and liver transplantation, there are various applications and say themes. So identification of suitable donor organs, prioritization, donor-recipient matching, and prediction of outcomes. And additionally, as I mentioned, there's an opportunity to model dynamics, which is something uniquely feasible with AI methods. So I'll start off by describing one particular project, and I'll go over this quickly because I realize that most people in attendance are not really in the liver transplant medicine field. But again, it gives you some insight into why we thought AI methods would be of interest here. So we know that in liver transplant prioritization and allocation, there is a disadvantage to female patients, and this was published some years ago in 2020 in JAMA Surgery by Locke et al. So the MELD sodium system, although it's dramatically say it did decrease waitlist mortality when it was introduced, it was realized over time that there was a disadvantage to female patients as well as patients with primary biliary cholangitis, and other subgroups, including acute on chronic liver failure. So, certainly, there were some disadvantages seen to certain subgroups. Now, the MEL 3.0 score, which has been introduced in the US as of last July, does rectify a lot of the female disadvantage, but there are other subgroups, again, which remain compromised. And so, having seen this in my own experience, I thought that this was an important question that we needed to address. So, one paper we had published from my institution was demonstrating that, in fact, female patients were much more dependent on the availability of living donor liver transplantation in order to get a transplant. And this was not ideal. Clearly, the deceased donor organ allocation system was unfair to them. And so I wanted to look into this because I was seeing a number of my patients passing away due to this disparity, and I felt that we should do something about it. And so I discussed this, important clinical problem with a computer science colleague, and he was quite interested to work on this problem, which is a huge problem in liver transplant medicine. In liver transplant medicine, I would also say that the indications for transplant are varied and complex and kind of heterogeneous. So it makes it a bit difficult also to put everyone on an equal playing field, in fact, in terms of prioritization on the wait list. And this is certainly a problem in countries where deceased donor organ transplantation is the main method by which patients receive organs. And living donor liver transplantation is not widely available, and the supply demand mismatch is significant. So, say supply is insufficient to meet demand. I felt that this was an important question. And we also were fortunate to receive grant funding to address this problem. Now, there has been a significant shift in the underlying patient cohort. So, many years ago, hepatitis C was the dominant indication for transplant, and now it's become more metabolic associated steatotic liver disease, so MASLD, which used to be known as NAFLD. And alcoholic liver disease. So these are the dominant indications for transplant. In the Western world, as well as in India, I realized during my recent academic visits in India. So our hypothesis was that some of the present inequities stem from inaccurate modeling. And so we used the Scientific Registry of Transplant Recipients, training an algorithm on adult patients with decompensated cirrhosis, and included several static and time varying features per patient. This was the demographics of the data set. We used a deep learning version of the Cox pH model and added rate of change covariates in there, so velocity and acceleration of blood tests over time, which we realized would be helpful based on our own experience. We thought it would be very interesting to include. And in fact, this was the idea of the computer science PhD student based on his in-depth understanding of the clinical problem. He really learned this clinical problem in depth and said, well, we should do this at each time point on the waiting list, include a rate of change covariate. And so this is, these are the features of this new approach. And we determined that the concordance, which is like, say, the ranking of a patient by time of death within 90 days, was much better represented by our score, which we call Dynameld, as compared to the variations of the MELD, as you can see here. And then we looked at the fairness, which is a pooled group concordance. It's a new measure of fairness and looks at the concordance over pairs where the first member is part of a defined protected group, for example, females. And so we determined that fairness was much better with this Dynameld model for both women as well as those with primary biliary cholangitis. And then now we are able to say predict individual risk trajectories using this approach, and noted that say patients, certain subgroups of patients would have been better served had they been evaluated under Dynameld or prioritized under Dynameld as opposed to the MELD scoring system. The additional interesting thing with this model is that now you can identify what are the top features or top risk factors that have led to this prediction. So reassuringly, the top features were the components of the MELD 3.0 score. But you can note that there are many people who actually have dependence on, say, first order rate of change in these different blood test results. And so these are actually quite important for many people within that cohort of patients. And so this is important to consider. And I think what's interesting is now we can actually predict for each individual patient what their trajectory could be in the next 90 days, and then say, okay, well, these are the top reasons for which their trajectory is going to be in this direction because they have say, an increased velocity in their bilirubin, increased velocity in their INR. And so this is why they have a much higher risk of poor outcomes on the waitlist. So this is, say, I think the interesting aspect of AI methods, the interpretability is feasible with what's called Shapley analysis. So these are the limitations of this work and next steps. And, certainly you can see this here. We're doing some external validation through a multi-center effort across Canada and incorporating patients with other indications for transplant beyond decompensated cirrhosis as well. Now, I'll move on to optimizing post-transplant patient survival quickly. These are papers that we've published in the last few years, really inspired by the need to improve long-term outcomes after transplant beyond the first year. So we know that our patients have a higher risk of cancer, cardiometabolic disease, and infection. And this was inspired by this need to change this and turn transplant into a cure, because we know that long-term survival beyond a year has not significantly improved in the last 30 years. So this work was published in Lancet Digital Health now 3 years ago. And we used several data points over time, so longitudinal data points, and leveraged a transformer model, which was the best performing model, to generate a more personalized risk calculator for managing long-term transplant care that could be used at each follow-up visit. And so we use the Scientific Registry of Transplant Recipients training on over 42,000 patients and testing on over 3,200 patients. This model that was able to predict 1 and 5 year outcomes. And as I mentioned, our best performing model was a transformer model with a survival AUC, so overall survival AUC of 0.77, and then various types of complications that lead to death also have an AUC that is reasonable, 0.80 to 0.81 for 1 year prediction, and this obviously decreases for the 5-year prediction. We then cross-validated on our external data set, our institutional data set, and performance was similar. So now what we are able to do is actually understand what are the, say, ranked features in each of these data sets that are leading to the prediction of outcomes. And we are actually now deploying this tool into the clinical setting via our electronic medical record system, which allows us to really personalize the care of patients. And I'm happy to get into this further during our discussion, but basically we are deploying this directly from our EMR to generate these personalized predictions for each patient, and then understand what is the, say, the reason or the contribution of each of these features to that prediction. And what might change if you were to modify, say, the immunosuppression by this percentage. Obviously, this is to be taken with a grain of salt, but I would say, there is this opportunity to even understand what would happen if you would change a parameter by this percentage in this patient, what would be anticipated to change in their outcomes. I'll move on to the last section of this presentation, which is optimizing post-transplant graft survival. So we published a paper a few years ago with Anna Goldenberg looking at chronic liver disease. So an ensemble machine learning algorithm that was developed by the first author student. So he was an undergraduate student in computer science who developed this algorithm, which was an ensemble algorithm to predict the presence of advanced fibrosis, and including various parameters. So I won't go into the details of this, but just to say that this again was the result of in-depth collaboration with this group and co-senior author Anna Goldenberg. So effectively able to detect advanced fibrosis with a sensitivity of 85%, specificity of 73, area under the curve of 0.87. So, in the liver transplant population, what we know is that cirrhosis advances very quickly. It arises in an accelerated manner as compared to, say, cirrhosis in the native liver. And what we need to do is optimize the outcomes of these patients by generating, say, personalized predictions of graft fibrosis and understanding how they might progress over time and potentially instituting personalized interventions to prevent this progression over time. So there are diagnostic options for fibrosis. Gold standard is liver biopsy, but this is invasive and associated with potential risks. There are non-invasive methods, but these are not, say, ideal and may not be done in a longitudinal fashion over time. So having something that can give you longitudinal changes in predictions would be very helpful. So this is work and a new ML method developed by Divya Sharma, who was a postdoctoral fellow in computer science, co-supervised with a colleague in biostatistics, and driven also by a clinical fellow, Amir Aji. So both of them worked to develop a new framework, a deep machine learning framework for dynamic diagnosis of graft fibrosis after liver transplantation, leveraging longitudinal changes in data over time to detect significant fibrosis, so stage 2 or greater. There were 29 variables collected, and this was the number of biopsies included as the training and the test sets. So 1,744 training and it was divided into 70% and 30% training and test, and then there was an external validation data set. And so she trained various ML algorithms, including conventional and deep learning algorithms. And she then fine-tuned long short-term memory networks, which is a type of deep ML algorithm, to increase the weight loss function. Um, so that the algorithm was better able to train on cases as opposed to controls, given that the cases were lesser in number. And this allowed for minimization also of bias with the weight loss function. And was better able to handle missing data. So with this algorithm, she achieved an AUC of 0.798. 100% of the cases were determined, and these were the top-ranked features for the overall population, which actually clinically makes sense and allow for a certain degree of trust in the prediction for the overall population. And so this also was published in Lancet Digital Health last year. And this is also another tool that we are now deploying into clinical practice. Finally, I'll conclude with Graft IQ, which is a diagnostic tool for graft pathology. So we see many different causes of elevated liver enzymes in our liver transplant population. And certainly a physician will have a hunch based on individual patient profiles. So you can see here, for example, a young patient with elevated liver enzymes in a specific pattern, most likely to be acute rejection. So we decided to develop an ML algorithm trained on clinical and laboratory data to identify graft pathology. Patients were divided into different histological diagnostic categories. These were the 6 main categories. And so the best performing algorithm was an artificial neural network algorithm with an AUC of 0.866. And these were the top 10 predictive variables for each of these categories. Now, we looked at the implementation of this particular algorithm and compared its performance to experts. And we realized actually when 12 hepatologists were asked to grade all of these cases, this was an exercise that we did as a group, and we determined actually that the medic was less performing in terms of accuracy of diagnosis as compared to the machine learning model. However, the machine learning model was making some funny mistakes in regards to specifically acute cellular rejection prediction. So then we decided, I asked Divya, how can we actually improve the performance of this algorithm? And she suggested, okay, let's feed some of these clinical rules that you have in your head. Let's encode these as prior knowledge and feed these using Bayesian inference principles to then integrate a weighted combination of probabilities generated by the machine learning model and the clinician. And so by integrating these clinical prediction rules, she was able to improve the AUC for diagnosis of these different causes of graft pathology. So this is an interesting, application and sort of improvement in the ML model performance using these clinical decision rules. So I think in the end, I'd like to say, I think that AI tools hold great promise to personalize the care of liver patients. Certainly, there are various challenges that we need to work on and understand, how to improve methods in order to optimize safety. There's a lot of opportunity given the large amount of data sets that we generate. And really, the next frontier is clinical deployment of these tools. As I said, that we need to carefully assess the predictions of to ensure that we are safe in the deployment and that we can all benefit from the predictions that are personalized to an individual patient. So improve patient outcomes, quality of life of patients, as well as say physicians and overall the healthcare system. So thank you so much for your attention. I'd like to also say that we have a transplant AI initiative at our center, which is comprised of various people with different skill sets, including machine learning and data engineering. We work very closely with our chief data scientist, Mike Brudno. My co-lead is Aman Sidhu. And so we're very excited to, say, develop capacity across our transplant program with the support from our transplant center. I'd like to acknowledge my, key collaborators across the University of Toronto, as well as my wonderful team, really highly interdisciplinary team that has various skill sets. And we all bring those different languages to the table, different skill sets to the table, and understand each other, more and more over time to inform interesting new projects and research. And I'd like to acknowledge the funding sources of my research program as well. So thank you so much for your attention and happy to take questions.
Thank you, Dr. Bhat. That was an excellent and very clear talk. Actually, it's always so informative to be an audience in your talks. We do have a few questions in the chat window. I think we can move on to the panel discussion, and then we can all sort of sit around the table virtually, and of course try and answer the questions.